Hello. Yep. Good morning, everyone. So next, I would like to share with you on the immunization implementation in Asia. So I will start with the what we have with the University of Oslo. Then I will go into more details on the Laos case, and then I will have few of my colleagues from few countries to also share their experience. Okay, so I will just show you first what University of Oslo has already prepared, and we'll spend a bit of time on the local adaptation and how, when we have the immunization, how can we link with other services in DHIS2, and that's what the plan in Laos, and I would like a few of the countries also to share. So start with the UIO data toolkits. So this is the toolkit that University of Oslo, in collaboration with WHO, HQ, UNICEF, CDC, and many organizations that have prepared this toolkit for many programs, and immunization is one of that. And as you can see, for immunization, there are many packages that you can use, starting from aggregate to event to tracker and more. But for today, we will focus on the EIR, but you can also find out more at the link below. So like I mentioned, the toolkit is the collaboration. UIO is working closely with WHO based on their guideline. They made the standard package where countries can download and customize for their own country. So with EIR, when they develop this, the main objective is to, first is to improve the routine data collection. So as you know, the aggregate will take some time when we want to make the monthly report, but with EIR, people just entered all the vaccine, and then the system can produce many reports, and aggregate is one of that. Another one is also data liability. So this is where you can also now see all the, for example, the appointment for the next vaccination, and also many variable. For example, they also have the program rule to check if the certain age, which vaccine that you need to give to the children. And as I mentioned, this package is designed with collaboration from WHO. There are also many countries' experience that contribute to this design of the package. So for the package, you can see, and you can view, they already configure for the birth detail immunization. So you can also look at the demo for more details. And these are the vaccine that pre-configure for you to see or to test. And this is a good way for you to start experience or doing the demo, or to prepare for your country, so that you don't have to start from scratch. And importantly, it's already available for Android and web, so that when you download and install in your local DHIS2, will be able to use for your Android and then the web as well. And it also comes with the indicators and standard dashboard that you don't have to configure again. It just works. So you enter data, then you can see how the indicators and dashboard are. So that's the global resource that's available. That of course it will be, they will combine many things that when you want to use it, you need to customize and adapt to your local settings. But it's a great point for you to have a look to see what is available, and then you can continue from that. You don't have to start from scratch. Next one, I would like to go deeper for Laos. So this is what we adapt from the global package, and then made customization according to Laos settings. But before we start, this is the lesson we learned before we move on to EIR. These are at least the prerequisite that we need to have, and especially in Laos. So that's what we learned. First, we need to have a standardized facility list and village list. So this is very important and very crucial. apart from that, then these two has to link. So for example, in Lao case, so we have the list of facilities, then we also do the mapping, like the catchment of each, the village catchment of each facility. So that will help you with more the report when you want to follow up the child and you want to make the population coverage. That is very essential. The third one is also the ID system, because when you use EIR or you want to track the child, you need to have one ID system that then can talk to other system, but also at the same time, when the child visit facilities, you can also they can use the same ID for tracking the child and get the child information. And the last one is on the SOP. So when we have that, we started with the Lao, we did the study. I think this is also common in many countries. So for Lao, we started with the aggregate, and the aggregate, also this is the simplified one. So the source for aggregate is from this logbook. So this logbook is by village. So if you can imagine, like this health facility is responsible for, let's say 5 villages, this facility will have at least 5 logbooks, and then another 5 for the outreach activities and other activities. And if you can see, the logbook is designed based on the child. So the child will be recorded uh, in the book and accordingly. But then when you want to do aggregate, it's very difficult, right? Because then you have to come to the vaccination when that happens. And if you can see, the child can get the vaccination at many point in time. And when you do the aggregate, it's very time consuming. And that's where we think that EIR can help, because you don't need to do this manually. Oops. Yeah, so you can replace that with standard report. So when you just provide the service and then you just enter the health facility, a health worker can enter based on the vaccine given, and then at the end of the month, at the end of the quarter, the DHIS2 can provide you the monthly report, the quarterly report with all the meaningful things. So that's the thing that we started with, and then we advise, and we have the UNICEF colleague with us who also help in the field that, okay, then if we don't need that one, the system can do for us. So we need to stop using this. So we started to stop using many of these, and we just have one, we call one logbook for this. So this one mainly is for to help health worker to enter data into EAR. So it's also reduced the number of the unnecessary columns. So we just focus on, for example, the child ID, the name, if this child is the old one or the new one, and then they have the date of birth, the parent's name, phone number, and then the vaccines, so that they don't have to how or you have to follow. And this is still for us, even we stop the logbook, but the paper is still important because of the system, as you know, like they can have some downtime. So to help with that, they can still have it in paper. And when they have the internet, when the internet is back, or when they do the outreach, they can come back and do data entry anytime. So they don't have to rely on the system all the time. So now when we move to tracker, these are the important fields that would need to record. So as I mentioned, for the prerequisite, we need to have the ID. So the ID also, we work with WHO and the colleagues to have a standardized ID. And this ID is not only used for EAR, but then it will be used for all the patient or the client. And the rest is also okay. And another part is the address. That's another important component, because that's where you want to know where the child is from and where is the child is going to get the vaccine and etc. So at least these are the minimum field that we need to collect for EIR to work. But in terms of the immunization, is very quite simple. And for now, we don't have a lot of vaccine, but we also have some here. So the vaccine entry page is just all the vaccine, but you also can have the program rule to show and hide. But what I would like to mention for this place is we also added the place of vaccination. So this is very important for to report and also for the health facilities as well, because now they will know the list of children in their catchment. And it's very important for them to follow that child. So even though that child is getting vaccine from other places, if that child is living in their catchment, they have to follow and to check if all the required vaccination is already met. So this is where we also can capture that. So we have fixed outreach mobile, then we can have outside of the country. That is also one of the major important part for Laos, because people can cross to the neighboring countries to get the vaccine. And to be able to capture that, we also need this. And then another one is other facility that I mentioned. Another feature for EAR is for the appointment, the next appointment. So when they finish the vaccination, they will get to choose the next appointment, which is in the past, they also have done that, but it's not really effective, because when you want to follow a child, you need to do it manually. You need to go through the book, but now we have the system. The system can alert the health center, health workers, as well as the parents when is the next the appointment. And as you can see, because the data entry part is relatively simple, and some facilities well equipped, they can do it real time as well. And as you can see, now they also see everything that they used to see in the logbook, in the book. They can see the child, they can also see the next appointment. So that's on the data entry, but for data use, I think this is the most important and where DHIS2 really shine. So in DHIS2, there are many analytics tools, and you can use it for data to use. But I will just show you on the standard report. That's where the health workers are really comfortable with, and they used to deal with the report, and now they don't have to make it, but DHIS2 can make it for them, and they still have the capability to use that to get all the report that they need from DHIS2. So this is the first one that I show you, the logbook. Now we replace this by the digital logbook, and also very more interactive and also more beautiful than the logbook. So they will have many information here that required for them to follow a child. And if they need to make the aggregate report, of course, you do EIR. If you complete all the vaccination data entry, then at the end of the month, at the end of quarter, or every year, system can compute the report, and then this can be sent to higher level if they need, or if they want to see how their facility perform, they can also use that for themselves. Another important one, and also a shift in the working culture, is this one. So like I mentioned, in the past, people, it's very rarely allows people for health worker to follow a child, right? Because it's the main one is very difficult. You have to go to the book, and there are many books. But now with appointment in the IR, you can generate the report. So what I'm showing here is for next month, for this facility, they can run the report, and then the system will check all the appointment for next month. And then we'll list you all the necessary information. We also have the vaccine in case you need to prepare. You want to know how many vaccines you will use, or how many child you are expecting to receive this month. But not over that, you can see the overdue. So if they miss the appointment, you can also check. And not just health worker, but at the central level or the provincial or the district level can also help to check these are the children that might have missed the appointment. You also have now with EIR, we have phone number, you have the address. The health worker can either call to check if this child is getting vaccine somewhere else, or maybe the parent forgot to bring the child to the clinic. So this is another report that you can, the health worker can check. And the last one on the report, this is also important for Laos, and also another reason why we need to move from aggregate to individual based. So for aggregate, we can have only facility service, where we can only know how many doses given at facilities. We don't know if this the child, where the child is from. But with individual base or tracker, we can have both. So if you want to know how facility is doing, you can do that. And if you want to do the catchment, that's very important, because if you don't know the address, you cannot count the children. It's very difficult to do that. But with EIR, it's possible. And this is what I can show here. That's the report. Now, coming back to the first point, now we have the mapping of the facilities and the village, right? So you know that the child in your area is getting the vaccine in your catchment, or is getting vaccine from somewhere else, or maybe from another country. And then if you can consolidate and make the report for you here. And then you can compare with the population, and then you can make the more accurate coverage, the indicator. But anyway, even though we started this switch from aggregate to AR for almost a year now, but there are some challenges that we need to work on to address. So of course, EAR, mainly you need to have a stable internet connection. In Laos is quite better now, only in a small certain area that they don't have stable internet, that you still need to rely on the paper and then send to district or to do data entry for them. The next one on the data quality, of course, when we change from one system, there will be some glitches that we need to work on. And the data use is still limited, as I mentioned, because that also about the new workflow that they have to adapt, and the new things that they need to be aware that is possible now with electronic immunization on DHIS2. There's also something about backlog, because they all need to do outreach every day. Mostly they also provide outreach activities, then we need to come back and then fill in the data. There are also the cultural aspects, for example, the names. So usually parents also use their nickname when talking to the health worker. And the last one also, there are some still resistant at the central level, where they are not really sure if this can work, or it will be too much for the health worker. So that we started with doing the phase-wise implementation. We don't stop everything at the same time, and then slowly we try to fully switch to tracker. So that's it for the EAR implementation in Laos. But then I will spend a few minutes on the tooling with all the services in DHIS2, right? Because right now we have the individual data, and I borrowed the slide from DG visit to come back to this client health registry. So now we have the base database from EIR. We can make that as the client health registry, and this client health registry, what we call it CHR, will be the integration link between many programs, and then other program can also utilize this. One use case that we are doing now is like, because delivery, we are also changing to individual base. So when delivery happens, you have the child record in the system, it will automatically push to the EIR program that now this child has been born, and then the immunization has the at least the ID and the few information that they can start to follow that child if that child is getting all the required vaccine or not. And that can happen for other program as well. And as you can see in the EIR program, we already started because this is the same child, right? You started with immunization, but you can have the birth detail, you have the growth monitoring, you have the child report. And anyway, because in health facilities is one health worker providing all this service. And I also borrowed this from Dr. Achala that WHO is also helping to develop this. As you can see, we started with vaccination, but for the child, it's more than that. Right? And the same child will have to uh, go through or enroll in many programs. And that's the possibility. When you have the one ID, you have the child, and when you want to record in vaccination, you can do that. And then in the well child also can be enrolled in that. And to follow the child, instead of just one program, you can do the child health development registry. And that's what we are doing. So we move from program centric. So instead of each program collecting their own information and having ID, we have one common ID to be shared with all the program, and all the health program are using the same ID to track the same child in this case, for example. Yeah, so it's just that for me on the immunization and a bit of our work in Laos. So because not only in this region, there are also many countries that are switching to EIR. So then I would like to invite maybe start with Maldives, because Maldives also have been doing EIR for some time to share their experience with us. You want to?
Good morning, everyone. I'm Difana from Maldives. I'll be sharing the experience our experience on implementing a digital immunization program, immunization registry in Maldives. Firstly, we wanted to digitalize our EIR records is to monitor proactively by central level also, because our islands are geographically dispersed. And to enhance data accuracy, moving from the old logbook to the digital system, we believe the human errors will be minimized. And we wanted to track the vaccination status in a timely manner. And for this, first phase of the work was initiated in 2022 January, and finally we were able to launch this system on October 2022. Of course, this is by the hard work of our core team members as well from the immunization program side also. And now we have trained all the facilities of Maldives, and the data entry has started from all the facilities, and we are continuing to monitor all the facility for their accuracy. And we are giving the training as well, and we have initiated a monthly meeting with the island facilities as well virtually. This will help to increase their quality of data as well. And yeah, the challenges we are facing, we have figured that there are duplication of child health records. So now we are uh, auditing the data we have already entered. We have actually captured data starting from 2022, and the auditing work is currently going on. So this will be resolved. And Also, this immunization program is expanding by including the growth monitoring and child developmental part into this system. And this is by capturing the child developmental part, we are intersectorally collaborating with our social and ministry to uh, by enabling a red flag mechanism to capture the delayed developmental milestone of the children. And we will be launching a public portal very soon for the public to view their vaccination information, and they will be able to generate a digital vaccination card of the children. And we are closely working with our consultant from his Sri Lanka team to start this soon. And I would like to add that because of the successful implementation of our EIR system in Maldives helps other program also to start uh, their systems as well. And we got motivated to work on other system as well, because we have already worked before also in digitalizing our systems. And we hope you got an our information of on our current EIR system. So thank you.
Yeah, thank you so much, Maudi, for sharing the experience. So next, I also would like to ask Bhutan to also share, because the case of Bhutan is a bit different on the immunization. Yeah.
Uh, Thank you so much, and good morning. Like many countries like many developing countries, in Bhutan also, our focus usually is on the service delivery, ignoring the information system. And at the end, we lose track of what we are doing, and we don't know what we have achieved. So similar case is also with the vaccination system also. Uh, Navigating the burden of the administrative burden is almost like planting a tree during the storms. So it might tilt a bit, but it will bear the fruit. So similar to that case, Bhutan vaccine system was actually developed during COVID-19. Uh, because there were so many things going on, people were engaged in COVID pandemic activities, and we did not really have a COVID system in place. So we developed something called a health facility system. And then from there, when the COVID vaccinations came up, we also needed some kind of a system. But we heard that there is a COVID system in DHIS2 as well, uh, which was, I think, implemented in Sri Lanka as well. But we could not go with that, as we had so many administrative hurdles or the barriers that we need to pass. The administrative clearance, resource mobilization, and also meeting with the donors. So in that case, then we went about with the Bhutan vaccine system. It was actually a few people came forward, a few experts, technical experts, or the ICT experts from Bhutan came forward and volunteered to develop a new system for Bhutan COVID vaccination. And yeah, I must say that rushed decisions in such desperate times is also gives us so many issues at the same time, giving the better outcomes that we really wish to achieve. So Bhutan vaccine system, as I said, it was actually to navigate and then enter the COVID-19 vaccinations. So it had the financial flexibility, the approvals were relatively easy. It was also developed in line with the GovTech agencies, data security policies. So it was actually easy to implement it in Bhutan. And also, since the system was developed by a Bhutanese team itself, so they were all the health team was engaged in COVID pandemic. So the technical teams, they themselves went to the districts and also trained the health workers on how to use it. So the training component was also not a burden on the Ministry of Health. Rather, it was taken by some other agencies. So during the COVID-19 it was almost a whole of a society approach where everybody came forward to work with the ministry instead of letting the Ministry of Health work on its own. Uh, it was also developed in line with the CRVS system. So we did not have to enter the data, personal data manually, which made data accurate, as well as there were very less chance of mistakes, making mistakes in the data entry. But as it started from scratch, there are so many bugs in it. That was a nightmare when people in the field were entering data. Sometimes they couldn't even open the system because of the huge number of people using that particular system at the same time. The carrying load was relatively less. So all this fixation took us really a huge resource as well as a huge amount of time. Uh, then another thing was with the customization. So Ministry of Health actually wanted something else. The developers did something else. So there were so many miscommunications, and we could not really have an established system. Unlike DHIS2, which is now a very stable and established system, Bhutan vaccine system was relatively new in the field. It has so many issues. Customization itself was issue, and sometimes people did not know what they were actually doing in the field. So these were the major challenges that we had to look at. Now, having said that, then the Bhutan vaccine system actually doesn't have all the routine vaccinations in it. So we are now focusing only on the HPV vaccination, the flu vaccination, and the COVID vaccination. So only these three vaccinations are now used in Bhutan vaccine system. And we also actually, there is no issue with the using of DHIS2 in Bhutan because health workers are all trained in use of DHIS2, and people are aware of the advantages of using DHIS2. But now with the coming up of electronic patient information system, we are actually trying to shift everything into the electronic patient information system where all the patient information, the longitudinal data, and the medical history of all the patients will be in the electronic patient information system. So we are also like on a ocean surface where we are sailed here or there with the current of the wind as well as the ocean current. So we are not really sure how the electronic patient information might turn out. But if it turns out good as we wish, and that is our wish, and we are putting in our heart and soul to make it happen. And if at all, if it doesn't work properly, then we might need to shift to the DHIS to EPI program. Thank you so much.
Yeah. Thank you so much, Bhutan, for sharing the experience. And last one we have from his Bangladesh. Also would like to share the experience in Bangladesh.
Good morning and assalamu alaikum. Thank you. The WHO launched the expanded program on immunization in 1974. And on the trend of that, an EPI Bangladesh was launched in 1979, 7th April. And from the beginning, the WHO is supporting the whole immunization program, and WHO mainly manages the data entry and everything. So, this was mainly centralized and mainly based on Excel. The later on, they moved to the access-based system. On the journey of HMI system in Bangladesh, we started in DHIS2 implementation in 2010. So in 2012, EPI officially requested to build based on the DHIS2 based EPI reporting. So as a part of German development cooperation, me and my team took the initiative to convert the EPI reporting, the routine EPI reporting in the DHIS2. Later in 1917, UNICEF and HISP Bangladesh supported development of vaccination logistics, cold chain, and other tracker-based implementation. In the development of HMIs in Bangladesh, we are very grateful to several people. One of them is Professor Dr. Ajad, who is the Director General of Health, Minister of Health that time. And we are also, another leader was Mr. Shukrat Rakimjanov, who is the head of health of UNICEF that time in Bangladesh. And I'm very glad that he is here in this room. And I like to apply for him. So the next thing I want to present is the MR campaign in 2020. This is one of the largest real-time monitoring of immunization campaign we have. So that was actually for the target was the 34.6 million children to achieve 95% within 7 weeks in 2020. So that was the target. And we took the challenge to build that system on DHIS2. So in DHIS2, we built that, and we have to follow, we make Android tools for the offline data collection and others. So you see the development of public dashboard so that the people can monitor real time. Every day they can know how the vaccination is going on so that there will be no gap and we can achieve the target of 95% was the target. We achieved 107%. 36.6 million people, children we vaccinated. So this is actually way beyond our imagination even. So we don't think that we can even achieve the 90% of the targeted 35 million children, but we achieved 36.6 million children vaccinated in 7 weeks. And everything within the DHIS2. So this is a bit of challenge for us and a scaling test for the DHIS2 as well. So the challenges was we have more than 500,000 org units. Be careful, 500,000 org units. Vaccination center, vaccination site, all is 500,000 more than. The user was 15,000. The 15,000 user reporting to the DHIS2 system. And we have to control, manage and everything within the DHIS2. And we are also very grateful to the DHIS2 core team because they supported us a lot that time. And performance of scaling is a really challenge, and we somehow manage that. And we built a public dashboard so that the data can be visualized every day so that the supervisors know where the gap is, if there is any logistics issue, and we have to address that. The second part I want to show you, the aggregated data collection. So there is several data collection, especially the vaccine logistics is there. So the vaccine logistics, we have the vaccine stock, supply and indent system built in the DHIS2. So that's actually worked very well for the vaccine logistics system inside our 636 reporting facilities where the vaccine logistics are reported and also any indent. So the indents and stocks are usually headquarter is weekly. The and other places is quarterly and monthly. So this is some example of aggregate data collection, public portal and DHIS2 portal. So left side is the DHIS2. This one is the public portal. The EPI management and macro planning. So the EPI macro planning, we have the sub-block level, where is 170 facilities, 110,000 facilities for the macro planning site. And yearly, there is a urban, for urban, we have 5,000 facilities. And this data is entered, collected in yearly. So have the yearly macro plan using as a denominator for the EPI reporting systems. So this is macro planning, aggregate macro planning, the dashboard. This is the public portal. So the immunization tracker. So immunization tracker, we have several immunization tracker. This is the routine immunization tracker, which is e-tracker. Currently is it implementing in 4,575 facilities. And total user currently is a 15,439 users. This is actually Android-based app, but DHIS Android app. So there we are using, initially we started version 34. Now we move to the version, you see this version 41. But later on, we actually moved to several other tracker. For example, we have the HPV tracker and the COVID. So the front end we changed from the DHIS to Android to our custom thing so that they can, those are one-time vaccination, they just scan the card, automatically the vaccine is registered and reporting is done. So thank you, everyone.
Yeah, thank you so much, Hanan, for sharing the experience in Bangladesh. So, and once again, thank you for all the presenters for sharing the experience. As you can see that for immunization, even though we start with immunization or we focus on immunization, but as I hope that you get the concept of doing this can be applied to many health programs as well. So now I think that's conclude for our immunization, and I would like to hand over to Anu for the next agenda.
Yes, so hi. Before we going for a tea break, we would like to arrange a 5 minutes Q&A session. So if you have any questions for immunization or even for climate work, yeah, you can ask our presenters now. We have 5 minutes. Yes.
Thank you so much. Very nice presentation, especially to Lao system, the EIR in Lao. So I think there are a lot of, how to say, interaction between different systems in Lao and starting from the deliveries to EIR and to other. So bring how this like together. It's basically I have two questions.
Hello, now like this one is.
Okay. Hello? Closer. Hello? Hello? Better now? Yeah, I think I have two questions actually. One is how you can identify the child. I know you have a patient-centric ID, but one patient move from one system or one place to another place. How you can identify them, or I mean, how will they bring this ID with them? So what happens if they lost it? Second question, the interaction between and the data exchange between different systems. Do you have a policy or a regulation for data security or privacy in place to share information, or it's like any agreement between different programs? Thank you.
Yes, thank you. I can address those two questions. So for the first one, how can we identify? You also mentioned that we are using client health ID, right? So each child or each client will have the ID. So the ID is also will be given to the client as well as part of the card. So he or she can travel with that card. But in case that card is lost, even though we can search for in the system. So you can search by date of birth with last name, date of birth with your address, etc. So that's where, and then every facility is using DHIS2, so you can do the search for the whole country. Now they will link to your second question because it's also linked to data security and privacy, right? Because people can search. And I would like to give two things. First, on the rule or the law or legislation. So that one allows we have the law on data, individual data, but that's from Ministry of Technology. They also have some certain guideline how you should protect that data. But for health, I think is a little bit special because that data for private and other companies need to be strict. But for health, it can be flexible. But we are working on making and adjusting that part to accommodate the health settings. The second one on the system itself, we also limit. So two things I can mention. First is we limit the search. Even though you can search for any, but you need to have more variables to search. You cannot just use the name or just phone and then you can search for anyone. So that's the first one. We do the combination of search. At least you need to know more about your client before you can do the search. Another part, we also utilize the log. So we set in the back end, for example, one health worker, you can search up to 100 records in a day for Lao example, because we don't have that much population and you don't need to search more than that. If you do something more than that, then the system can flag, oh, somebody is using searching so much, we can at least stop that, not allow the search and wait for the review. So these are the few things we are doing, and I hope I can answer your questions. Yeah.
Okay, thank you, Sam. So I think we have time for one more question. So anyone have any question?
Thank you. My name is Mana. I would like to ask a question regarding the linkage to other system in terms of the health patient. I don't know whether you have already thought of linking the LMIS, the logistics management information system, into this linkage.
At the moment, we have not, but that's another plan. We would like to utilize that logistic to compare the utilization of the vaccine versus the patient. And at the moment, it's not in place. We just started with EIR, but obviously in the near future, we will need to link with them.
Thank you.
Thank you.
Just to follow up on that question, like we have a LMI session tomorrow morning where Breno is sitting in the front. So if you have anything, you can always catch him. He's our LMIS person. He will have a presentation on that. But yes, Anu?
Yes, so thank you, John. We would like to invite all our participants for a tea break now.